Hello, everyone. This is Mazen Kerala, and this lecture is part of a crash course for critical care fellows. We will be discussing the assessment of hemodynamics, and we will use a pathophysiological approach for this assessment. And we will start with some principles in hemodynamics, then define shock clinically, then present the different types of shocks before we end up with some case studies. So the first principle that you need to understand is the Frank-Starling curve. As you all know, the stroke volume is dependent on the preload. The higher the preload, the higher the stroke volume, till you reach a point in the preload where any higher preload will not result into higher stroke volume. And that's why you have this Frank-Starling curve taking this shape. The second principle that you need to understand is the venous return curve. And the venous return to the right heart is dependent on the difference between the mean systemic filling pressure and the right atrial pressure. The higher the difference, the higher the venous return. So as you see, with the right atrial pressure going to 0, we have a higher venous return. If the right atrial pressure goes below 0, that venous return does not increase any further. The third principle that you need to know is the Ohms law, which dictates the flow inside a dynamic closed circuit. And the circulatory system is very similar to a dynamic closed circuit. And the flow is affected with number one, the difference between the inlet pressure, which is P1, and the outlet pressure, which is P2. In addition, it is related inversely to the resistance. The higher the resistance, the lower the flow. So the formula would be flow equals change in the pressure divided by resistance. The higher the change in the pressure, the higher the flow. The lower the resistance, the higher the flow. And then let's take the change in the pressure to the left side of the formula here. So the change in the pressure, which is P1 minus P2, would equal flow multiplied by resistance. And the P1 in our circulatory system is the mean arterial pressure, and P2 is the right atrial pressure. So let's replace the P1, P2 by the mean arterial pressure and the right atrial pressure. The flow is the cardiac output, and the resistance is the systemic vascular resistance. If we are looking at the mean arterial pressure, then we need to move the right atrial pressure to the right side. We can replace it with a CVP. And the formula would actually be rewritten as mean arterial pressure equals cardiac output multiplied by systemic vascular resistance minus CVP. Let's omit the CVP since it is a usually low number, doesn't affect our understanding of hemodynamics, and work with the formula of mean arterial pressure equals cardiac output multiplied by systemic vascular resistance. So when we have a patient with hypotension, we need to look at the determinants of mean arterial pressure. Again, this is our formula, and it is represented in this graph very nicely. The mean arterial pressure equals to the cardiac output multiplied by the systemic vascular resistance. Now, the cardiac output is determined by the stroke volume and the heart rate. And the stroke volume is determined by number one, the preload, number two, the contractility of the cardiac muscle, and number three, the afterload that is located centrally in the chest. At the same time, we have the autonomic system that would compensate for any changes in these determinants, where the adrenals are released and affecting the systemic vascular resistance positively, increasing the heart rate and increasing the contractility. So if your patient is hypotensive, the differential diagnosis would be, number one, a problem with the preload. The preload is decreased. Number two, contractility is decreased. Number 3, afterload is increased centrally. Number 4, abnormality in the heart rate, either bradycardia or tachyarrhythmias. And number 5, decreased systemic vascular resistance. Let's not get confused between systemic vascular resistance and afterload. Systemic vascular resistance is systematically at the level of the vessels. What we mean here in this graph by the afterload is the central resistance against the pumping of the heart. An example of that would be pulmonary embolism, and we will see one example later. And of course, it could be also a combination of factors. So the decreased mean arterial pressure could be caused by any combination of this 5 different factors. And of course, we may have a defective autonomic system compensation mechanism that is contributing to the hypotension and shock. And we can also represent the hemodynamic system by the 3 main components of that system that would dictate the blood pressure. First, we have the contractility of the heart, which is the pump. And then we have the vascular resistance. And again, this could be systemic and it could be central. And then we have the capacitance tank and the volume of the blood, which would dictate the preload. Again, the preload is needed for the stroke volume based on the Frank-Starling curve. And then the heart will need to overcome any central or peripheral resistance. So let's define shock syndrome. Definition of shock is hypotension, which is defined as a decrease in the systolic blood pressure less than 90 millimeter mercury, a drop in the systolic pressure by 40 millimeter mercury from baseline, or 20% from the baseline, or mean arterial pressure less than 65 millimeter mercury. So any one of this would actually define a hypotensive state. But in order to say that this is a shock state, we need evidence of hypoperfusion. This could be a high lactic acid or organ dysfunction, such as kidney dysfunction with decreased urine output. At the same time, you can look at different types of shocks based on the oxygenation status. And we deliver oxygen to the tissue, and then the tissue consumes oxygen. So we may have 2 different types of shocks. The first one is we do not deliver enough oxygen to the tissue, and this could be caused by a low cardiac output state or a low arterial content of the oxygen. Again, oxygen delivery, we talked about that in our oxygenation assessment lecture, but oxygen delivery is related to cardiac output multiplied by the arterial content of oxygen, which is related to the hemoglobin level, the hemoglobin saturation, and the dissolved amount of PO2. So a low cardiac output state will give you a low cardiac output delivery, which might be the cause of the shock. On the other hand, we may not have a problem with the oxygen delivery, but the tissue is not able to utilize the oxygen, and the oxygen consumption is decreased. Oxygen consumption is calculated with the cardiac output multiplied by the difference between the arterial oxygen content and the venous oxygen content. In these cases, usually the cardiac output either normal or high, but the tissue is unable to extract oxygen, such as the case in cyanide toxicity or severe septic shock. We can also look at shocks in terms of the systemic vascular resistance. And we have either distributive shock, which has a low SVR syndrome, and resistive shock, which is a high SVR syndrome. So a high SVR, meaning the systemic vascular resistance, is increased because of the compensatory mechanism of the adrenalines that are released in the body. This could be because of hypovolemia, cardiogenic shock, or obstructive shock. And in those cases, the cardiac output is low. The other type of shock where we have a low systemic vascular resistance, this could be because of sepsis, anaphylaxis, adrenal failure. And we will talk about different differential diagnosis of this shock later on. But the cardiac output in these cases would be elevated. In neurogenic shock, it will be low SVR, but the cardiac output is also low. So I should actually remove it from this differentiation here. So in other words, we can look at shocks based on the SVR, whether it is low or high, and clinically we can incline about the state of the SVR by looking at the pulse pressure and the skin temperature, as we will see later. It is important to understand the capacitance of the vessels. The normal capacitance, where the resistance is normal and the volume is normal, is going to be compared to three different conditions: hypovolemia, distributive, and cardiogenic. So you can see this is the vessel size, this is the capacitance, and inside it, the volume of the blood. Compare this with the hypovolemia. What you see is the volume of the blood is less and the resistance is increased. You can see vasoconstriction, a high SVR in this condition. So there is vasoconstriction with volume depletion. In distributive shock, there's a vasodilatation. The same amount of volume of the blood is now distributed in larger capacitance, and this may decrease the preload on the right heart. So the volume is actually variable depending on the etiology of this too. And then in cardiogenic shock, you can see that the vessel is constricted. So you have vasoconstriction and the volume is increased, giving you an overload in the volume and vasoconstrictive shock with high SVR state. Now, shock syndrome can actually be represented on our graph very nicely here. If we have a decreased preload, this is hypovolemic shock. If we have decreased contractility, this is cardiogenic shock. Increased central afterload is obstructive shock. Any abnormality in the heart rate is cardiogenic shock. And a decreased SVR or systemic vascular resistance is distributive shock. And finally, a decrease in the compensatory mechanism in the autonomic system is neurogenic shock, which might affect the systemic vascular resistance, the heart rate, and the contractility of the heart. Now, in our clinical assessment, we need to take those determinants of the mean arterial pressure one by one and evaluate them clinically to make a decision about the condition of that determinant. So we can actually determine the state of the preload or the volume status of the patient with our clinical examination, with stroke volume variation. If we have the device suitable for that, we can look with the ultrasound at the diameter of the IVC or the IVC variability with the respiratory movements, and we can do echocardiography and measure the end diastolic volume. For contractility, we need to do echocardiography to assess the contractility of the cardiac muscle. And if we have any of those semi-invasive devices, or if we insert a Swan-Ganz, we can directly measure the stroke volume or the cardiac output for the patient. We can incline about the systemic vascular resistance from the physical examination, cold temperature of the skin, and narrow pulse pressure will indicate that the SVR is elevated. Warm temperature of the skin and normal capillary refill time, along with wide pulse pressure, would indicate low SVR syndrome. Again, if you have a semi-invasive method to measure or to calculate the systemic vascular resistance, you will be able to assess this parameter in a better way. You can also look at the chest X-ray, the echocardiography to assess whether there is any increase in the central afterload for the patient. And of course, you can look at the EKG and the rhythm of the heart to assess the heart rate. This is a differential diagnosis of different types of shocks. We're going to be detailing in this with our clinical cases that will be presented next. So the first case is a 34-year-old male who was involved in a motor vehicle accident and arrived at the emergency room with a blood pressure of 70/45. His heart rate was 142 per minute. He had cold and clammy extremities. Of course, here you can see that he's got much more severe injuries than what's been described in this case scenario. So our patient, of course, has hypovolemic shock, apparently because of blood loss. However, we can represent this on our diagram here very nicely, that the problem is actually in the volume of the blood here. So we have less volume. With that, there's an increased high vascular resistance as a compensatory mechanism. Now, based on the Frank-Sterling curve, the stroke volume is decreased because of the decreased volume or decreased preload to the heart. However, the contractility of the heart would actually be normal if we have the volume. So what happens with less volume or less preload, the stretch of the myocardial fibers would be less and the contractility will be decreased. But the pump function itself is normal once we have the volume. That's why it is important that we replace the volume as soon as possible for those patients. So the stroke volume is low. And the third thing is the systemic vascular resistance is increased. So if we look at our clinical examination, as I mentioned, extremities will be cold, clammy, patient will be tachycardic, and he has evidence of hypovolemia with empty veins, for example. According to our diagram here, the problem is in the preload. So the preload is decreased. And as a result of decreased preload, contractility is decreased and the stroke volume is decreased. Now, because of the decreased stroke volume, cardiac output will be decreased. However, compensatory mechanism tries to increase the systemic vascular resistance, increase the heart rate with tachycardia, and of course, try to increase the contractility also, but there is no enough preload to increase it. Therefore, this mechanism, if it was not enough to counteract the effect of decreased preload on the cardiac output, the patient will become hypotensive and he will go into shock when there's evidence of hypoperfusion. And the parameters for our clinical assessment, let's take a look on the first row here. So we're going to look at the systemic vascular resistance clinically. And we're going to assess this with the skin temperature, with the capillary refill time, and with the pulse pressure. Then we're going to measure those determinants of preload. Here we have CVP. We have the pulmonary artery occlusion pressure or wedge pressure, and we have the stroke volume variation, but you can have other parameters too. And then we assess contractility, and we're going to assess that with the stroke volume, cardiac index, and cardiac output here. Don't forget that cardiac output is stroke volume multiplied by heart rate. And then afterload, we're going to call afterload or the systemic vascular resistance and the central vascular resistance and the central resistance as afterload in this table here. So we'll explain that clearly, which is with each case. So here we have a patient who's hypovolemic, and the skin temperature is cold. The capillary refill time is prolonged, more than 3 seconds, and the pulse pressure is narrow. This indicates that we have a high SVR syndrome. So this is the compensatory mechanism in a patient whose primary problem is hypovolemia. So the hypovolemia is indicated by the decreased CVP and decreased wedge pressure, as you see here. Since there is hypovolemia, stroke volume will be variable, will be more than the variation in stroke volume will be more than 10%, meaning that the patient will benefit from volume repletion. As a result of the decreased preload, the stroke volume is decreased and the cardiac output is decreased, and the compensatory mechanism will increase the systemic vascular resistance in this condition here. The differential diagnosis of hypovolemic shock could be hemorrhagic because of trauma, such as in our case, could be internal bleed, GI bleed, retroperitoneal bleed, or any other bleed. It could be just fluid depletion, non-hemorrhagic, because of external loss of fluid with dehydration, vomiting, diarrhea, polyuria, or redistribution of the fluid in thermal injury, trauma, and anaphylaxis. And of course, it could be because of increased vascular capacitance with venodilatation, such as the case in sepsis. So that's why we will see that the preload may be decreased in patients with sepsis without evidence of hypovolemia. It's just the volume is distributed in larger capacitance of the vessels. You can see that in anaphylaxis or in toxins or drugs. The second case is a 54-year-old male with acute onset chest pain who arrived in emergency room with blood pressure of 70/50. So notice these two cases, the pulse pressure is narrow, 70/50 in this case and 70/45 in the previous case. The heart rate is increased at 140 per minute because of the compensatory mechanism. And of course, this patient has cardiogenic shock with cold, clammy peripheries and decreased capillary refills because of the increased resistance or systemic resistance. So we can see that here, this is cardiogenic shock. And the main problem is the pump. So you can see that the heart is not able to pump blood. As a result of the decreased pumping mechanism of the heart, the body will try to compensate with release of adrenalines and increased systemic vascular resistance. So we can see increased vascular resistance as a second component of this shock. Now, in terms of the capacitance tank, we have mild vasoconstriction, but the heart is not able to pump out the blood, and we have high volume in the capacitance tank. And that's what actually be manifested clinically as cold, clammy peripheries with decreased capillary refill, and you may see evidence of fluid overload with high JVP. On our diagram here, the main problem is decreased contractility. As a result of decreased contractility, the preload is increased and the stroke volume is decreased. The patient will have a decreased cardiac output, and compensatory mechanism will try to increase the systemic vascular resistance and the heart rate. If this is not enough, the patient will become hypotensive and he may go into shock if this is protracted. And on our clinical assessment, we're looking at the second row here. Again, clinically, we will see that the extremities are cold, capillary refill time is prolonged, the pulse pressure is narrowed. The main problem is contractility. So you can see here the stroke volume, cardiac output, cardiac index are all decreased. The preload is increased. You see that with increased CVP and wedge pressure, the heart is unable to pump out blood. And there is no stroke volume variability. So SVV will be less than 10%. And of course, the systemic vascular resistance would be increased because of the compensatory mechanism. Differential diagnosis, it could be myopathic, secondary to myocardial infarction, such as, or in a condition of hibernating or stunned myocardium. We have failure of the right ventricle because of multiple reasons, acute pulmonary embolism or massive pulmonary embolism, for example, is a myopathic and obstructive at the same time. Myocardial contusion in cases of trauma, myocarditis, cardiomyopathy, septic myocardial depression. We may have medications that can cause decreased cardiac function, such as cancer medications or calcium channel blockers or any other medications. We may have a mechanical reason, could be valvular failure, stenosis, or insufficiency, hypertrophic cardiomyopathy, ventricular septal defects, and we may have an arrhythmic cause of the cardiogenic shock with bradycardia or tachyarrhythmias. The third case is a 67-year-old female with fever, chills, shortness of breath, and as you see, very ugly looking abdominal wound. Chest x-ray with ARDS looks like patient is intubated, arrived in emergency room with a blood pressure of 70/30. So notice the pulse pressure, 70 minus 30 compared to 70 minus 50 in the previous case. Heart rate is tachycardic at 135 per minute. Skin is warm and capillary refill time is 2 seconds only. So in this patient, we have a problem with the vascular resistance. So this is our primary problem here. There's a decreased systemic vascular resistance. As a result of that, there's increased tank capacitance because of vasodilatation here. The volume may be the same, but it is distributed in larger capacitance right now, and the preload may be decreased to the heart, but the heart is pumping effectively, and you will see that the cardiac output in those cases is high. And clinically, those patients would manifest with warm, dry peripheries, tachycardia, and the pulse is pounding. On our diagram here, in distributive shock, the problem is in the systemic vascular resistance. And as the result of decreased systemic vascular resistance, we have compensatory mechanism that will try to increase the heart rate and increase contractility. That's why the stroke volume is increased for those patients because of the contractility, provided that the preload is enough to provide the stroke volume. And the cardiac output is increased, but if the cardiac output is not able to counter affect the decreased SVR on the mean arterial pressure, at that time we'll have hypotension, which may go into shock if we have hypoperfusion. And on our clinical assessment here, the third row, where you see the skin temperature is warm, the capillary refill time is decreased or normal, and the pulse pressure is wide. You can see difference between systolic and diastolic blood pressure. Now, the main problem is afterload. Again, this is systemic. Systemic vascular resistance is decreased. As a result, compensatory mechanism will try to increase the contractility of the heart rate, and the stroke volume, cardiac output will be increased. In terms of the preload, it is variable actually. It depends on the volume stat of the patient, but because of increased capacitance, the volume is distributed in larger tank at this point, and the preload may be slightly decreased, but again, it is variable. It may be normal or increased. The stroke volume variation is dependent on the volume of the blood or the intravascular volume, and it will be variable. The last case that, because before we get into that, causes of distributive shock would be either sepsis, any kind of organism that causes septic shock, toxic shock syndrome, anaphylactic shock, adrenal crisis. Neurogenic is actually a combined shock, it's mixed shock between distributive and cardiogenic. In those cases, you will see that the SVR is low and the heart rate is low along with the contractility of the cardiac muscle. But it is one of the differential diagnoses if you have a low SVR syndrome. Toxic distributive shocks, such as in nitroprusside or Britidium, and liver failure, or in SIRS with acute severe pancreatitis, rejection of transplant, post-cardiac arrest, post-cardiac bypass machine, and other conditions. The last case that we have is a 56-year-old male with acute onset chest pain and shortness of breath who arrived in emergency room with a blood pressure of 76/53. And his heart rate is 137 per minute, cold, clammy peripheries with decreased capillary refill. Look at the CT scan and you will be able to appreciate that there is massive pulmonary embolism and the pulse pressure is narrowed, tachycardic, extremities indicate high SVR. So in this type of shock, which is obstructive shock, the vascular resistance is increased, but it is central. The heart has to pump against an obstruction at the central level that could be because of pulmonary embolism, tamponade, or any other condition. And because of the obstruction, the pump is unable to pump out blood. So there is a low pump effect. Contractility would be okay if there's no obstruction, but we're not able to pump out blood out of the heart. And the volume is normal in the capacitance tank. Clinically, those patients have cold, clammy extremities, have decreased capillary refill time, and may have raised JVP. Again, clinically, conditions that can cause obstructive shock could be massive pulmonary embolism, cardiac tamponade, constrictive pericarditis, tension pneumothorax, or mediastinal tumors. Again, what we mean here in this condition with the vascular resistance is the central vascular resistance. In our diagram here, the problem is in the afterload, which is central. So that is increased. If it is increased, it's ineffective to pump out blood and stroke volume is decreased, cardiac output is decreased, compensatory mechanism tries to increase the systemic vascular resistance and tries to increase the heart rate. But if this is not enough, the patient will become hypotensive and then he will go into shock. And on our clinical assessment, this is the last row here. Clinically, there's an indication of high SVR, extremities are cold, capillary refill time is prolonged, and the pulse pressure is narrowed. The main problem is the afterload. This afterload is increased because of central obstruction. It is not the systemic vascular resistance, but at the same time, the compensatory mechanism tries to increase the systemic vascular resistance in this condition. As a result of the increased central afterload, the heart is unable to pump out blood, stroke volume will be decreased, and cardiac output will be decreased. And that will lead to increased CVP on the left side with the wedge pressure. It depends on the clinical condition. Wedge pressure will be decreased in pulmonary embolism because you don't get blood to the left side, and it will be increased in tamponade because you're constricting on both ventricles. And of course, the stroke volume variability or variation will be variable dependent on the volume status, but most of the cases will be less than 10%. In fact, you have obstruction towards the venous return, so you don't see much variability. With this, I think we'll try to end this talk. However, we have here the causes of extracardiac obstructive shock. You can look at impaired diastolic filling problems, just such as direct venous obstruction. So this is the filling to the right side of the heart is impaired. We may have increased intrathoracic pressure with tension pneumothorax, with extra or excessive PEEP in patient who's volume depleted, in dynamic hyperinflation syndrome of asthma, especially if you put them on the ventilator and you give them high volume with decreased, with shortened expiratory time. Decreased cardiac compliance in cases of constrictive pericarditis and cardiac tamponade. You may also have impaired systolic contraction with increased ventricular afterload, and that's what we mean by central afterload. On the right side of the heart could be pulmonary embolism, massive pulmonary embolism, or acute pulmonary hypertension. On the left side will be left ventricle, on the left side would be aortic dissection as an example. So I want to conclude by putting this slide again. It is very important that you put this diagram in your mind in any case of hypotension, where you need to examine those determinants of blood pressure one by one. You start with the preload, clinical assessment, echocardiography, ultrasound, stroke volume variation. You go to contractility with echocardiography. You look at the chest X-ray, ultrasound of the lungs, echocardiography for the heart to determine any etiology of increased central afterload. If you have semi-invasive methods such as PICO, flow track, you can measure the stroke volume. Of course, you can look at the area under the in the arterial waveform. This part would represent the stroke volume, and you can see any variation that may indicate the status of the preload. If you want to learn more about determinants of fluid responsiveness, please review the separate lecture that is available under the education tab on the website. Then you need to assess, of course, the heart rate with the rhythm that you see on the monitor. You need to assess the systemic vascular resistance. You can do that clinically with the temperature of the skin, the pulse pressure, or the capillary refill time. And if you have PICO or flow track, you can also calculate the systemic vascular resistance more reliably. With this, I hope I was able to give you a better way to assess hemodynamics in patients with hypotension, so you can manage those patients in a better way. Thank you.